Thank you very much for your kind introduction. Good afternoon, ladies and gentlemen. My name is Marie Oshima, and I'm with the University of Tokyo. Before my talk, I'd like to express my sincere appreciation for your kind invitation. It is a privilege to present our recent work on a computational hemodynamics. Today, I'm going to talk about the patient-specific blood flow simulation with a machine learning technique for clinical applications. Let me start with this the patient case. This is a 78 years old male, and he experienced a stroke induced by a severe stenosis presented in the left intercoronary artery. And he came to the neurosurgeon who we've been working together. And then, the neurosurgeon decided to conduct revascularization surgery, because if this situation was left, the worst case is he would die. So the neurosurgeon conducted carotid artery stenting as shown on this slide. And the surgery went successfully, and the flow was recovered. However, the next morning, this patient experienced a hemorrhage due to cerebral hyperfusion syndrome. And because of that, he had to have an emergency surgery. And after that, he suffered from paralyzation. So if we know the impact of surgery on cerebral circulation before surgery, we can avoid the complication like CHS. There will be another way for surgery. So how can we find out? So that's why we'd like to predict a risk of a CHS by using patient-specific simulations. And so my talk, the outline as follows. First of all, I'd like to briefly touch upon the introduction and objectives. Today's talk focuses on cerebral hyperfusion syndrome, which usually happens to a patient with a very severe stenosis. So I'm going to talk about the carotid artery stenosis. And since we are trying to apply machine learning technique, we need to have learning data. So in order to obtain the learning data, we use a patient-specific 1D, 0D simulation. Why don't we use a three-dimensional simulation results? But I'm going to talk about why I'm going to use a 1D, 0D simulation, which is a reduced order model. And once we have a learning data, we are trying to conduct uncertainty quantification using a surrogate model. Usually, we incorporate medical image data of a patient-specific data, and that would contain uncertainties, and that would affect the simulation results. So that's why we need uncertainty quantification. So I'm going to talk about that, why we need uncertainty quantification, and how we're going to perform uncertainty quantification. And we use a surrogate model. And then I like to present some of the patient case and the results. And since the machine learning can conduct a sensitivity analysis, so I'm going to talk about that. And then I like to conclude with a summary. So let me briefly talk about carotid artery stenosis and then cerebral hyperfusion syndrome. CHS is an abbreviation of cerebral hyperfusion syndrome, and it usually could occur following the surgery for severe stenosis that I just presented in the beginning. The surgery is usually recommended because it is a major risk factor for ischemic stroke. And usually the stenosis is over 70%. The neurosurgeon recommend to have a surgery, either endotheliectomy. I always cannot pronounce this correctly. Its abbreviation is CAE, or stenting. And then for this revascularization surgery, sometimes the CHS happens. The CHS, however, has a very low incidence, which is about 0 to 3%, but a very high mortality rate. It is about 38% once it develops. And definition of a hyperfusion as defined as shown in this figure, in this equation. This mean is the flow rate in the brain after the surgery becomes twice as much as those before the surgery. So if we compare the difference between before and after the surgery, we can diagnose the risk of the CHS. So the objectives of our research is we like to find out the patient-specific treatment, and we are focusing on the cerebral vascular circulation. And we need to investigate the flow after surgery, and that requires the flow distribution in the entire circulatory system. So that's why, what happens is that when you conduct the surgery, the flow in the entire circulatory system changes, not only the local region. So that's why we need to have an entire circulatory system, and that is a very large simulation, and that would be very difficult to conduct. So that's why we use a 1D, 0D simulation, which is a reduced order, the model to conduct a simulation for the entire circulatory system. In addition to that, even though we have a very accurate simulation, we cannot avoid the uncertainties included in the medical image data. And for the patient-specific simulation, we need to use a patient-specific data. So that's why we need to have an uncertainty analysis. So the objective is to predict the initiation of a CHS, and we are trying to develop a data-driven surrogate model, and then using a 1D, 0D model, and with a multi-model medical image images taking account of uncertainties. As I mentioned, why do we need uncertainty quantification? We use medical image data such as CT, MRI, SPECT, ultrasound, all the medical images available for the simulation. And also we use model parameters because it is very difficult to have patient-specific information. For example, like stiffness of arterial, the blood vessels. And that's why we use an empirical model for that. So the uncertainty in measurement data will propagate through the simulation. For example, model parameters can be obtained using the measurement data, and then all together with measurement data and the parameters, the simulation will be, the results will be obtained. So that's why the answer, it is very important to understand the effects of uncertainty in the simulation. So for the uncertainty simulation, the quantification, there is two things that we need to keep in mind. First thing is we need to reduce the cost of individual simulation. Usually we need to have it's a very we need to if we use a very large number of sample, it is very hard to conduct uncertainty quantification. And the other thing is we need to reduce the number of simulations. Usually we use a Monte Carlo method for the uncertainty quantification. That's why the number of simulation does matter. So that's why the uncertainty quantification cannot be performed without the use of large-scale computational resources. And that's why we are trying to develop a surrogate model. And the surrogate model is developed by the machine learning technique with a data-driven approach using the reduced order simulation. In this case, 1D, 0D simulation. So this slide summarizes the pipeline of uncertainty quantification. First of all, we need to obtain learning data for the uncertainty quantification. So we use, for the set of learning data, we have input and output, and the output will be obtained by the 1D, 0D simulation with a stenosis model like this one. So this is empirical simulation, the model. And once we have a learning data, we use this neural network for training. And this will lead to the surrogate model that we are used for this study. And for the uncertainty quantification, we vary the input data, such as like a geometry, which are obtained from a medical image data, like a CT and an MRI. And also we obtain the velocity data from like a ultrasound or 4D flow or PC MRI. And we have the uncertainties vary in the range like this, and we conduct the uncertainty quantification using the surrogate model. And then we can obtain the probabilistic distribution of a risk of a CHS. So this is a pipeline for the uncertainty quantification in this study. So let me explain about 1D0 simulation. If you're interested in, please refer to this the paper that we published. The 1D model consists of continuity equation, Navier-Stokes equation in 1D set. And also we consider the compliance of the blood vessels. So that means that we need a relationship between pressure and area, which is given by this equation. And we also combine 1D, 0D, 1D simulation with 0D simulation, which is consists of electric circuit like this. And this equation is for mass conservation, and the other equation express momentum equation. And since we deal with stenosis, we use the model for stenosis. The 1D simulation cannot deal with a separation caused by stenosis. That's why we use a 0D model for in the separation to express the like a separation. And this 1D, 0D simulation expresses the closed loop of entire circulatory system. And the 1D simulation is simulated using a two-step low-Lax-Wendorf scheme. And a 0D simulation is simulated by a fourth-order Runge-Kutta scheme. And 1D, 0D is coupled together, and this will be solved by Newton-Raphson method. And this is a summary how we conduct patient-specific simulation. We use the geometry information from MRI or CT, and then we will extract the diameter and the length of each patient vasculature. And also we use the velocity information from ultrasound or PCMRA. And also we need the output flow information that comes from the SPECT. So that will give you the flow in the peripheral region. And also, as I mentioned, we consider the compliance of artery, the cerebral artery, which comes from the empirical relationship like this one. And then for the learning data, we have 60 input data, and then we have 45 output data. And these input and output set will be obtained by the 1D, 0D simulation, which I was just described. And also a total of 200,000 samples of input and output were obtained. And then the data was divided into the training and validation and test data in the ratio of 6 to 2 and 2. And for the, well, in order to conduct the machine learning, you need to tune the hyperparameters for the training. And this figure shows the effect of hyperparameters on the training. And the hyperparameters that we obtain is the number of the hidden layer, and we also have 200 nodes. And as you can see on this figure, it's not either under fitting nor overfitting. So those hyperparameters are used for this surrogate model. And also the number of training sample is very important. And we also conduct some study how many data set that we need. And according to, as shown in this figure, 120,000 data set will be good enough. So that will be the data set that we use. And a verification of a surrogate model is conducted. And as I mentioned, we divided the data set into 6 to 2. So the 40,000 test samples are used. And it shows a very good verification results. So this surrogate model is applicable for this study. And the good thing about the surrogate model is it's a very, we can have the computer time will be reduced. 1D, 0D simulation is very fast and very effective in computer time comparing to three-dimensional simulation. But still, it takes about like 5 minutes. And if you wanted to try like 200,000 in simulation, we would take a tremendous time. But once we have a surrogate model, the computer time is comes down to like about 7 milliseconds. So the surrogate model will give you answer very quickly. And also they can be done in a parallel way. So using a GPU, we can conduct the uncertainty quantification in a very effective way. So let me move on to the uncertainty quantification. What we did is we are trying to predict a risk of a CHS. So what we do is we conduct the simulation to obtain the situation before the surgery. And then we conduct the computer-assisted surgery on the computer. What we did is we expand the stenosis area, so that's why we can virtually emulate the carotid stenting artery on the computer. And then, as I mentioned, risk of CHS can be predicted by the difference in the flow rates between before and after the surgery. So we compare the flow rates before and after the surgery. And for the uncertainty quantification, we change the input condition, for example, geometry and velocity within an uncertain region. And then we can obtain the distribution of the difference in the flow rates before and after the surgery. And let me show you the results. We are conducted uncertainty quantification using 3 patients. The first patient, I'm sorry, is he has a mild stenosis, and patient 2 have 83% of a stenosis, but he had a high risk of a CHS. And the last example is, I'm sorry, I have to move this, the Zoom. Otherwise, I cannot put the cursor here. The last one has a high stenosis ratio, about 91%. So let me give you the results. But before that, that patient 2 has a very high risk of CHS. Why do we know that? Because the neurosurgeon conducted the SPECT measurement before he performed surgery, and usually this SPECT is done to find out the peripheral perfusion in the brain, and then he usually the rest condition is measured, and then you put ACZ, which is a stimulant to expand the blood vessel, and then you can find out the deceleration ability of each patient. And if the deceleration of artery is good enough, he or she doesn't have a risk of CHS, but this patient didn't have this kind of ability, so that's why it has a very high risk of CHS. And the neurosurgeon conducted the staged stenting, like shown in this figure. So he just expand a little bit and see the situation, and the situation becomes stable. Finally, he put the stent. So that's how you can avoid the CHS risk. So what we did is if we expand the stenosis 100%, what's going to happen? So that kind of thing can be done in a computer simulation. So the patient 1 doesn't have any CH risk, and then as shown here, it doesn't have any risk. By the way, if the risk becomes like over the 100%, that means this patient has a CHS risk. And the patient 3 even has a very high stenosis ratio. He doesn't have a CH risk, as it's also predicted correctly in our simulation. And patient 2 has a high risk of CHS, and as shown in this figure. It's predicted successfully. And a good thing about the machine learning is that we can conduct a global sensitive analysis, so which parameter affect the results. And then we can find out that if the patient doesn't have a choroidal flow in we call circular wheels, the patient will have a very high risk of CHS. And then let me summarize our study. We presented the method to conduct a surrogate model using a machine learning technique with simulation data. And also we conduct uncertainty quantification for predicting the risk of hyperfusion. And as I explained, we can predict the risk of CHS as a medical doctor diagnosed. So finally, I'd like to acknowledge my co-authors, and then thank you very much for your attention. I'd like to happy to take any questions you may have.